I want to welcome you to our briefing today. I'm Mike Capaldi. I'm the Executive Director for the Institute for Gene Therapies, or IGT for short. Unfortunately, I'm here standing in for Eric Paulson. Congressman Paulson had several canceled flights over the last 24 hours and could not be with us, but he sends his warm regards to all of you. If you're new to the Institute, you should know that our mission is to advocate for modernized policies that encourage transformative gene therapies, but also promote access and codifies transparent reimbursement practices. So that's our mission and what we do every day. And this is our second briefing on the Hill here this year. I do see a couple of familiar faces from the first one, and hopefully you're starting to learn more about the Institute and gene therapies. Now, notably, last Thursday, we did want to recognize that the FDA approved Elevidys, which is a gene therapy that treats Duchenne muscular dystrophy, and that was actually the disease that we focused on in our last briefing. And so that's great news for patients with Duchenne as well as their family and caregivers. Now, I do want to acknowledge several of our advisory committee members who are here with us today. You can learn about all of them in the packet that you received when you entered, but we have several of our corporate advisory council members here, as well as many from the patient and scientific academic community. So we'll have plenty of time to mingle, of course, afterwards. Look forward to that. But we want to have the majority of our time to be hearing from our tremendous panel here that you'll meet in one moment. To do that, I'm going to invite our scientific, academic, and medical chair, Dr. Donna Christensen, to introduce them. We could spend the entire hour talking about Donna's accomplishments. I feel very fortunate to work with her. Just a couple that I'd love to point out to you. First of all, her impressive record of serving 9 terms in the House of Representatives. And being a physician by training, she was the first female physician ever to serve in the U.S. Congress. So quite a historical figure and a leader in the space. So without further ado, Donna, I'll turn it over to you.
Thank you, Michael, and good afternoon, everyone, and welcome. We're so glad to see you here today because we're here to discuss a really important topic, and several important topics, actually. And we want to discuss the value of gene therapies, the value that they can deliver, not only to patients, but to families, to the scientific community, and really to the country as a whole. Gene therapies are therapies that give us hope, and you'll hear some of that from some of our panelists today, it'll actually help to address the inequities that we're seeing in our healthcare system. Importantly, all of us at IGT are working to ensure that all patients who may benefit from gene therapy have access to these life-changing treatments. This is an issue that's near and dear to me as a physician, as you've heard, as a former member of Congress, as the former chair of the Congressional Black Caucus's Health Brain Trust, and just as someone who has always has always been an advocate for patients and families across the country. Of course, you'll hear a lot about one of the diseases that we are glad will benefit greatly from gene therapy, and that's sickle cell disease. According to the CDC, sickle cell disease affects approximately 100,000 Americans, about 1 in every 365 Black births. We're honored to have this panel today. We're honored to have Dr. James Taylor, the director of Howard University's Center on Sickle Cell Disease. He's here to share some of the work he and his team have been doing and to share information on the incredible science that makes these treatments different from from pharmaceuticals and biologics. We also have with us today Regina Hartfield, the president of the Sickle Cell Association of America, which advocates for sickle cell patients and families across this country. And they've been doing that for many years. I'm sure Ms. Hartfield will tell us just how long and hard they've been working on those issues. And not really last, but definitely not least, is Shanetta Richardson, who's actually living with sickle cell. And she's here to share her journey with us. We're also happy to have IGT's own John Feore to dive into the policy issues, which I'm sure will also be of importance to all of you who are gathered here today. I'd just like to recognize in the audience the chair of the board, Dr. Thompson, of the Sickle Cell Association of America. Thank you for joining us today, too. So we're going to begin with questions, and we're just going to have sort of an interactive discussion here today. And this first question is for everyone. And the question is a general one about what does gene therapy mean to you personally. But I want to begin with Shanetta, because I want you to begin by telling a little bit about your journey as you answer that question.
So my name is Shanetta Richardson. I've lived with sickle cell disease, type SS. Sickle cell is very near and dear to my heart, not just living with it, but I have over 5 generations in my family who had sickle cell disease. Unfortunately, some of them didn't make it in a transition. Living with sickle cell disease, growing up always in a hospital, I was affected to the point where I was temporarily blind at the age of 7. The age of 18, I had a crisis in my spine and was temporarily paralyzed from my neck down, so I had to learn how to walk again. It affected every aspect of my life as well as education. I got my GED confined to a hospital bed, but I also got my master's degree in public health administration. So it affected my life tremendously. The work balance, the school work balance. Then around the age, in my early 20s, I went through the bone marrow transplant process. And I had a donor, which was my brother, and it didn't work for me, it didn't take for me. And, with that, going through that clinical trial and not getting the aftercare or the follow-up care or the mental health check really affected me tremendously. So what gene therapy means to me personally, it means progression, it means advancement, it means hope for the sickle cell community. And with gene therapy, you don't need a donor. You can use your own genetic DNA to help make protein in your body to help you have a more effective life that you desire, the quality of life that you desire, because sickle cell is so unpredictable. What people really, when we talk about sickle cell, they generalize sickle cell. Sickle cell is not a generalized disease, it's an individualized disease. It affects everyone differently. It's different types of sickle cell. So when you do gene therapy, it's tailored to the individual and their type of sickle cell. So that for the sickle cell community is advancement. And with that being said, going forward with gene therapy, I just want to make sure that, we know the good, the bad, the indifferent, so we can make a sound decision. And I think that will help the community overall in promoting gene therapy. I think if we just be honest and talk about everything that we're going to experience down the line or the pros and the cons ahead of time, then I think it'll be beneficial for the sickle cell community.
Thank you. Thank you so much. Go ahead and pass the mic to Ms. Hartfield. And I know you've been around this disease for a while and have probably seen a lot of the advancements as we are approaching the advancement of gene therapy being available for our patients. So go ahead and tell us a little about the association and the question.
Well, I am delighted. I'm Regina Hartfield, the president of the Sickle Cell Disease Association of America. I have been honored to be in that position now for a year and a half, and prior to that was on the board for a couple of years. I have a whole speech, but I will just, in the interest of time, say The Sickle Cell Disease Association of America is composed of 52 community-based organizations. These organizations are on the ground every day doing the work with those living with sickle cell disease and their caregivers, supporting the efforts from a clinical setting, providing support services for everything from housing to food to relocation, and making sure that those who are needing the help of each and every community-based organization can receive it for a range of services. These 52 organizations span 29 states across the country, and so our footprint is wide, and the work that is done is deep. And we are honored to be able to speak on behalf of those living with sickle cell disease. And to be here today to talk about gene therapy is incredible. We are this close to a cure that will transform how people live and the quality of life and the hope for tomorrow. And I think that there's nothing more exciting and more promising than where we are right now in the sickle cell space. Thank you.
Great. Dr. Taylor?
James Taylor from Howard University, the Center for Sickle Cell Disease. Sickle cell research in the United States started at Howard University, and we are the oldest center. It was founded in July 1971, which really isn't that long ago. The disease has been around for long before that, but has kind of been ignored. So when we talk about access to care, I think that's one thing that's very important to me. I was talking with my social worker today about a patient who needs heart surgery because she's in the hospital all the time with heart failure and sickle cell disease, and she has no health insurance. So I've singled out a heart surgeon who probably will do this for free, but those are the types of things that we worry about every single day in sickle cell, access to care. And so this type of curative therapy, it's hope and it's progression. And right before the pandemic, we were doing a 5K walk at Howard.
I was going to ask you to tell that story.
Well, one of the first patients who received gene therapy for sickle cell said it was about 3 months and she felt great. And I was walking with the president of Howard, who has sickle cell anemia and hasn't had gene therapy. He was walking kind of slow because he's anemic. She was moving faster than I was. Unfortunately, she passed away, but these are the risk benefits. And to hear somebody say that I've never felt this good in my life or this normal about 3 months later, I think that's the hope and promise of this type of therapy. We just want to make sure that it's accessible to everyone, but in terms of quality of life and the ability to work and pursue your own interests, I think this is the real promise of this.
John, are we going to leave you to the end, or you want to talk about policy?
Sure. I'll bring up one.
What does gene therapy mean to you?
Yeah, I'll bring up one topic that the Institute for Gene Therapies is working on. Really, a campaign is defining the value of gene therapies. And when we think about sickle cell, there's no greater example of the value that gene therapy can offer. Beyond the expense of constant hospitalizations, readmitting yourself to the hospital, inability to work, caregiver burden, family burden. There's so many elements of value beyond just the medical cost savings, premium savings or claims savings that gene therapies promise. And so whatever the disease state that a gene therapy is seeking to potentially cure and treat, the value narrative goes far beyond that, and that's something at IGT we're trying to help explain to policymakers, to the press, to whoever we're going to speak to, whoever's going to listen, and help make this message clear. And I think we can see that pretty clearly with the patients.
Dr. Taylor, you have some numbers that would compare. I mean, you know that one of the big barriers is cost. So
Sure.
Can you talk about the cost.
Well,
of
I just want to
care?
dovetail on his.
Yeah, piggyback on that for me.
I want to piggyback on his comments. I think all of the types of genetic diseases, sickle cell just happens to be the nation's most common genetic disease. Coming from a minority population, so think about that. 10% of the population produces 100,000, and the next most common disease is 3 times less common. But all of these diseases are equally miserable. Hemophilia, cystic fibrosis, take your pick. In terms of sickle cell, I think, though, the cost is astronomical, and I'm just wrapping my head around it after 20 years. We have one patient that I did a deep dive into, and I fixed him, but in 2021, he was in the hospital 18 times, 106 inpatient days. That's on IV opioids, IV morphine, 106 out of 365 days, and another 35 ER visits on top of that. But what the kicker is the billed claims on that were $789,000. But the hospitals only got reimbursed 11% of that value, about $91,000. We instituted some really aggressive therapy and some behavioral therapy and involved a psychiatrist, a multidisciplinary team. We cut his cost to $310,000, and the paid claims on that, what Medicaid actually paid was 31% of that bill, which is about $99,000. But when you're dealing with one patient and volumes of money that large, it's huge. And even Howard University Hospital, that one patient led us to a deep dive into, we've defined our financial losses to 8 sickle cell patients, each of whom is losing $1.2 million a year in unreimbursed billed claims. Those numbers are staggering. So that's the value of something like this. Sure, it's going to cost a lot, but in the long run, it is much cheaper than having somebody live for 40 years as an adult at that price tag.
So our next question, and we'll just keep going back this way to Dr. Hartfield. So what do you think are the biggest misconceptions about gene therapy and sickle cell maybe?
I would say some of the biggest misconceptions about gene therapy focus on people's concern about what this actually means. What is the full scope of it? Am I cured and I will never have another related illness? And that's not necessarily the case either. But I think also people are afraid that they will be experimented on, that there really is not a way forward, and I think that's another misconception. And I do think that people are concerned about what this means. Am I going to be able to live my life? But in the short term, in recovery, how is my family going to be? My family is not going to be able to survive this journey that I might want to take. And there are so many, as you mentioned, support services that are in place that people don't even realize yet. They have the opportunity for mental health. They have the opportunity for support services with the expenses of the day-to-day living, as well as with their health care needs. So the more we educate, the more we inform, the more we talk about this gene therapy, and the more we really give real-life experiences and bump up all of the options against the real-life experiences, the benefits will outweigh all of the other concerns, and more people will be interested in learning more about it. The other thing I just also wanted to give a plug to is for clinical trials. If it were not for the clinical trials that took place in order for us to get here with gene therapy, we wouldn't be here with gene therapy. And for the individuals, especially for individuals of color, to take that leap of faith and to participate in these trials was incredible, and we want to give them a thanks even though they may not be in the room with us today. But that was a very, very critical part of the success of being at this point with gene therapy.
And Shanetta, going through emergency visits, hospital visits, I'm sure there are a lot of misconceptions and stigma that you may have faced, and that all patients that I have ever known with sickle cell have faced. Can you talk about that a bit?
Yes. The stigmas that I faced are going into the emergency department and being labeled as a drug seeker, not understanding the severity of the pain that I am in. So we have to put in extra effort to even get the help that we need or the care that we need. It's almost as if you have to convince the staff of who you are and what you're going through and how to be treated for sickle cell. Most individuals with sickle cell living with the disease, we go through this process with the emergency room and even with our physicians on a monthly basis. So we know what works for us and what don't. But because we're educated and knowledgeable about our health care and we're very proactive in that area, we get labeled and they would think that we are just drug seekers. But even just that, as a community as a whole, it's twofold. So you have the patients that's going into the emergency room that's being treated and stigmatized. But then you got the patients that go through hospitals to hospital to hospital, which in return creates the stigma. So for the ones that do go into the hospital and be treated with the emergency department, they don't know, they're not educated as much. So they don't know not to give you steroids when you go into the emergency room because that would trigger a sickle cell crisis. They don't know just the basics.
And what about working? I listened to the Roland Scott seminar, and I heard a lot of stories about people having difficulty keeping a job.
Yes, because living with this disease, you don't know how you're going to feel from one day to the next. It's unpredictable, and 1 minute you can be fine, and you can be doing a little better, and you can push through the pain, but sometimes the pain is so severe that you can't walk, you can't move, and then the medications that you're on is just like you're on a roller coaster. And then the effect that with my job, my work experience, I just was employed with an agency, and I had a supervisor say, is it a such thing as sickle cell? Does it even exist? I'm in a hospital getting care because I'm having a severe crisis on top of not being able to breathe and having other problems. But for your supervisor and the chief of the department to call you at the hospital and say, if you don't come out the hospital and come back to work, you're going to get fired. So it's a misconception. It's just a stigma that's attached to sickle cell. And it's a lot of people that do not understand what sickle cell is and how it affects the individuals that's living with it on a daily basis.
Thank you. So, let me see.
Can I make a remark on that?
Sure, please. And if anyone else wants to make a comment on that.
So what you described is what we hear so much at the national office about the emergency department and the quality of care. We're not talking necessarily just medical care, but the quality of the interaction. You look at someone as beautiful as Shanetta is, and you think, what's your problem? What could possibly be the problem? But without really understanding the level of intractable pain, of the frightening position that you're in when you are trying to explain to people what's going on, when you are telling them to please call my hematologist and he or she will tell you what to do. And maybe the physician will call the hematologist and maybe that person will, they'll have a conversation and still have the emergency department physician say, I'm not going to do that. I'm still not going to do it. So one of the things that SCDAA will be doing this year at our annual convention in October is we are working with an organization called EDSC3, and we are hosting a summit on the emergency department and the issues that are happening. It's time for a national conversation about this. It's time for everyone who has been talking about it here and there and everyone to come together. And I think once that happens, it's not just one person here having an issue, one person here having an issue. The aggregated conversation is going to make a difference. It's not going to solve everything that day, but it certainly will give us an action plan for moving forward. Thank you.
Okay, and before I go to John, a lot of our questions have really been answered, but is there anything anyone would like to add to what some of the barriers that patients face when it comes to accessing gene therapies?
Accessing gene, okay, do you want to go first?
The insurance, the funding. They came out with a couple of drugs in the past couple of years, and we don't have access to them because we don't have insurance to cover them. So we need to be accessible even to receive it. You know, if it's out there, we need to be able to receive the therapy and be able to access the therapy. But funding, the insurance companies are not covering it. So that's one of the barriers that we go through. And just having all the information.
So it's just a recent study, retrospective study, looking at Medicare and Medicaid claims, and we now have 4 FDA-approved drugs, but only since 2017 for sickle cell disease. Only 2% of sickle cell patients have access to those therapies. They're reasonably expensive, $100,000 a year, pretty par for the course for most genetic diseases and types of therapies, but we're not seeing widespread access.
Okay, did you want to add anything?
I did. For the concerns about access and care, a lot of people are not getting the information. They are not hearing the information. And so if they are not able to have these conversations because potentially their HCP, you know, they're incredibly busy. They may not have the time to devote. They may not have all of the information. Individuals don't even realize that there is an option, so they don't ask. They don't know what they don't know. I know on the Eastern Shore of Maryland, there is no trained SCD hematologist at all. So anyone who needs treatment by an SCD-trained hematologist has to leave the Eastern Shore. And if any of you have ever tried to get across the Bay Bridge, imagine having to come when you are getting treatment or when you have sickle cell. So these are critical areas. The other thing I would just say is the infrastructure across the board. The current delivery infrastructure for sickle cell disease does not meet the needs of the population. There are areas in the country where there's just, as I mentioned, no resources, there's not enough information, not enough time and place in the facilities that there are, issues of transportation and so many others. And because of that, people are not able to get the care and the quality of care and the consistency of care that they should have and that the national standards require them to have. So they are suffering needlessly. There are physicians who are trying and working really, really hard to support their sickle cell patients, and they too are not able to get the information or the medications or the instructions that they need to share with their patients. So it is critically important that these pieces of legislation that have been reintroduced on the floor and that are pending in the appropriations, getting all of these voted on, enacted, and funded would be a game changer for the existing needs in the sickle cell disease community. It would strengthen the care delivery infrastructure and provide a fantastic basis for when gene therapy is ready. Because right now, if gene therapy were signed off on and everything was rosy, the insurance companies paid, everybody had access to it, we would not have the delivery system in place to be able to support that, because we don't quite have it yet to support the existing needs.
So I have a great quote from the CEO of Jefferson Health in Philadelphia. and it's very apropos to sickle cell disease. We are trying to implement 21st century cures, and we have a 19th century healthcare delivery system.
Okay, maybe we'll turn to John and talk about what Congress can do to begin to address some of the things that we've heard about and especially the things that IGT is dedicated to doing, which is making sure that the access is there for everyone who would need it.
Yeah, thank you, absolutely. So thinking about when a new drug is approved, new therapy, whether it's gene therapy or some drug to treat symptoms, it's important to remember that Medicaid is supposed to cover every single FDA-approved indication the day it's approved. Not 6 months down the road, not a year down the road, not deferring to a neighboring state to try and provide that coverage. Same with the Medicare program. We have to hold federal officials that are overseeing those programs to account so that there are access barriers. For certain diseases, genetic diseases where you have a disease progression, one month can be the difference. We don't have time for a 435-day back and forth between a couple states. So there are certain areas like traveling across states to receive care, particularly in the Medicaid program, where there needs to be some leadership from the federal CMS level, some guidance to help us get to a more palatable situation. One of the things that IGT is working on is expanding alternative payment arrangements, value-based payments. There's a lot of terms with varying degrees of definition. We don't want to limit any type of coverage or any type of value-based payment to one type of payment, whether it's a outcomes-based contract or a payment over time or a Netflix. We want flexibility from the federal government payers to look into discussions with manufacturers and figure out a way that makes sense for that payer or that state program, whether it's Medicare or Medicaid, in terms of implementing this. I know our corporate members at IGT, they want to look into where it's doable to have these value-based payments or these alternative payment arrangements. Medicaid has a multiple best prices program that was enacted not too long ago for the drug rebate program. With some champions we have on the Hill, we're promoting the MVP Act, Medicaid Value-Based Payments for Patients Act. That's another tool to help spur the adoption and greater use of value-based payments across Medicaid. So those are a couple of things we're working on. There's a whole host of issues afterwards. Happy to talk into some more specifics with individuals.
Thank you. Thank you, Donna. How about a round of applause for our panelists? Thank you so much. Perhaps that last interchange there can provide hope to all of us that if we find ourselves faced with a debilitating disease, there are others that we can speak to who might be going through the same thing. There are professional associations who work on behalf of all of us, and there are specialists who care for us one patient at a time, and in some cases across an institution. And so I know that gives me great hope. And as the executive director of the Institute for Gene Therapies, we know that we're entering into an era of precision medicine. And that era requires us doing things structurally different than we've done in the past. So I want to thank all of you for being here today and simply put a plug in for our website, gene-therapies.org. Again, gene-therapies.org. If you're new to gene therapy and it's still a bit mystical to you, that's okay. We have some resources, educational resources there for you. If you're already savvy on the policy and you want to see what our positions are, you can learn those there as well. So again, thanks to our panel. Thank you, Donna, for moderating. And we hope you'll stick around. We have some refreshments here, and please mingle with one another and hope that there are more exchanges like we just witnessed. Have a great evening.